So currently, we have 3 FDA-approved combination therapy for advanced stage HCC. But when we treat patients with advanced HCC, sometimes we see significant tumor shrinkage, and those patients are able to make it to a curative procedure, such as resection. So naturally, we would want to see, we would hope to provide that to patients with a little more disease than what usually we can resect. And of course, to extend that is, should we give patients with immunotherapy if they are candidate for resection as just a pure neoadjuvant therapy? So you can see for unresectable HCC, we try to downstage it to resection. For patients with resectable disease, we would like to give them therapy to lower the post-surgical recurrence risk. And currently for HCC, when they get the resection, the risk of recurrence is very high. We are not supposed to do cross-trial comparison, but we sometimes cannot help to look at the data cross-trial. And so if you are thinking about a neoadjuvant regimen, so you want to shrink the tumor significantly for patients who are not resectable to start with, and you try to give them therapy to shrink the tumor so they can become resectable. And then you hope to give patient a regimen that with high response rate. So there's a high likelihood to shrink the tumor. And so you would look at the regimen that has probably highest response rate. Having said that, we've seen significant tumor shrinkage even with regimens that in the trial has not shown the highest response rate. So I guess we've seen significant response tumor shrinkage from any of those regimens. So the nivo-ipi response rate is 36%. Bev-atezo, 30% on the trial reported, and for tremi-durvalumab, the response rate is slightly lower. But what we still observe, patients get significant tumor shrinkage from any of those regimens. When I look at the trial, I would look at treatment-related adverse events, serious treatment-related adverse events, or grade 3-4 treatment-related adverse events. And so you can see some combinations, the percentage is a little higher than other. And, but those regimens, those are not new signal. And we've observed that with the same regimen in other cancer. So we've not seen HCC-specific adverse events with those regimens. So it's not a surprise to see those numbers. And I think given the experience we have managing immune-mediated adverse events, and we actually feel relatively comfortable managing it. Having said all that, if patient is elderly, I always try to picture the patients if they don't report to us as much and they're elderly with comorbidities. If they get serious immune-mediated AEs, are they able to, how well they are able to handle it? And based on that, I would pick the therapy a little differently. Currently, the data on recurrence rate is all based on older data. Patients have not had any immunotherapy as a neoadjuvant therapy. This is from the surgical database or publications, and on patients who had resection without any neoadjuvant therapy. The risk of recurrence depends on the publication, can be as high as 60 to 80%. So it's very high risk of recurrence, and over the years, we have trying to apply adjuvant therapy in trials, try to lower the risk of recurrence. We had negative trials previously, and we had a negative trial with TKI, the negative STORM trial. We tried to use sorafenib to lower the risk of recurrence. The study was negative. And then recently, now in the modern area, we've under IMBRAVE 050, we treat those patients with bevacizumab, atezolizumab for a whole year. We hope to see lower the risk of recurrence, and that study initially reported positive, but with longer follow-up become negative. So we still need to work on it, and now with more options, I think we need to keep trying. We need to keep, there's an unmet need. Those patients have high risk of recurrence, and we need to do something to lower the risk, to prolong survival. That's a tricky question. So I think a lot of research activity are ongoing from early stage to advanced stage disease. So from early stage, there are a few other adjuvant trials have compared single agent combination, some study even bispecific antibody combination in the adjuvant setting. They finished enrollment and we're waiting for data to come out. So we don't know if those studies will read positive. And so that's for early stage disease. Intermediate stage disease, and we're also testing combination immunotherapy with local regional therapy. And recently we had two studies that reported with TACE plus immunotherapy combination. And currently there's immunotherapy plus Y90 radioembolization as a local regional therapy modality in combination with immunotherapy, and that is ongoing. So we hope to see some results from those studies. In advanced stage disease now, we have studies testing multiple immune checkpoint inhibitors in first-line therapy. We also are testing other type of treatment, such as ADC, antibody drug conjugates, and CAR-T vaccine, and other precision oncology medication. We try to test those in a second-line setting. So it is hard to predict which will become positive. And there are a lot of work has been put in to trying to find a biomarker. So far, we have not been able to really identify a specific biomarker that would predict a benefit from the treatment other than the alpha-fetoprotein predicting ramucirumab. But for the combination immunotherapy, we don't have a biomarker. We hope with the AI technology, there's something exciting will come up, but right now it's hard to predict if we'll find the biomarker or not.